everybody. Welcome back to Psychedelics Today. This is your host, Joe Moore, coming at you from Breckenridge, Colorado. Today on the show, we have Julie Zukof and Dr. Michelle Weiner of Psychedelic Women. This is a really fun podcast. Julie and I met a few weeks or months ago in Miami, and I was really impressed with the project Julie has, Psychedelic Women, about to launch. It'll probably be launched in full force by the time this interview comes out. Yeah, and I also got to see Dr. Michelle do a really cool panel presentation, and I think even a direct talk talking about ketamine and her practice around chronic pain, talking about the psychic contents on pain and pain experienced. So really interesting stuff. I was impressed. I think I even from the back of the room yelled out something like, "Can you please explain why ketamine is not the next opioid epidemic?" Because that's what people say regularly, and I don't really agree with that thinking. So it's just such a different compound. So yeah. Anyway, I think that's it for now. Really excited to bring you Julie and Michelle, and this is a really important project, so be sure to check it out. And I'm hopeful we'll get a lot more female inclusion going forward in the psychedelic space as a result of their efforts. So thank you both for being on. Can't wait to do episodes with you individually in the future. And yeah, hope you all enjoy. And if you want to help us out, share with a friend, leave us a review on Google, Facebook, Spotify, wherever you're listening. And yeah, we would love it. And give us a follow on socials. Love to see you there. All right, everybody. Thanks for listening, and we'll see you on the other side.
Summer is here and things are getting mighty busy over at Psychedelics Today. We've got 5 offers and events to let you know about, and you can find all of them on psychedelicstoday.com/events. The first one is happening on Saturday, June 25th. It's a live podcast being recorded in Vermont. It's at the Rail Yard Apothecary in Burlington. And the same day, so Saturday, June 25th, Psychedelics Today is partnering with Remap Therapeutics and Clusterbusters for a virtual psychedelics and pain symposium. Monday, June 27th, we have a webinar, 12:30 Eastern, Iboga use in the Bwiti tradition and urban ibogaine treatments. And that's a presentation by Brazilian psychologist Bruno Ramos Gomez. And next week, a 3-day in-person and virtual conference by our friends at the University of Exeter in England. And that is titled Philosophy and Psychedelic Studies Hybrid Conference for Emerging Scholars. And if you live in Oregon and you like to read books, then I would direct you to a giveaway we have. giveaways.psychedelicstoday.com/giveaways/Oregon Starter Pack. And we're giving away 3 sets of 3 books. Psychedelic Psychotherapy by R. Coleman, The Psychedelic Explorer's Guide by James Fadiman, and Your Psilocybin Mushroom Companion. We're going to pick out 3 lucky winners. You've got until midnight on June 28th. All right, have a great day, everybody.
Hi, everybody. Welcome back to Psychedelics Today. We have some cool special guests here. We have Julie Zukof, Dr. Michelle Weiner, and we are talking about Psychedelic Women. Julie, can you give us just a high level of what is Psychedelic Women?
Yes, Psychedelic Women is a community of influential women that are in the psychedelic space, whether they work in it, they're interested in it, they're passionate about it. And it's a community, a membership community, and a platform. So we connect women together and we provide a platform for exposure through speaking engagements, introductions, and just supporting each other.
That's amazing. And when was it founded?
It was founded in January. I was going to conferences and speaking engagements, and I was seeing that women were the minority on the panel, similar to the early stages of cannabis. And I thought, how can we change this? And you change it through, advocacy and speaking up. So the whole point and mission is to raise women's voices in the space and elevate them. So more exposure, more features, and more mentions.
I love it. And how did you bring Michelle in?
Yeah, so we started in January with a panel with Michelle. Dustin Robinson does a psychedelic series at Soho House. He has for about a year. And I approached him about launching Psychedelic Women during one of his panels. And so for one of the months, Psychedelic Women did a takeover of the psychedelic series at Soho. And Michelle was on our panel along with Dr. Denise Vidot and Bianca Abbott, a nurse focused on ketamine. And we launched then, and Michelle really was the inspiration for Psychedelic Women because she was the token psychedelic woman on the panels. And I thought, how can we get more women on these panels and give them that opportunity?
Right. And at a recent conference in Miami, we'll leave it unnamed for now, I guess, I got to meet you both. I didn't meet you, Michelle. I got to watch you present and be on a panel. And I was really psyched about everything I was hearing. Just really happy that there's this kind of activity in South Florida. This kind of quality level of debate is happening. And not to mention, you're in clinical practice. Can you, Michelle, introduce yourself and kind of just briefly speak about the kind of work you do right now?
Sure. I'm a pain management physician. I've been in private practice for probably 12 years, and I did physical medicine and rehab, really more of like an athlete into nutrition. Musculoskeletal medicine was really my background, and then I did interventional pain. And after a few years of practicing in South Florida, because of the opioid epidemic, and I just got really frustrated with the lack of tools I had. I started integrating cannabis into the practice, and I got very involved in our Florida program here. And so I trained a lot of the physicians in cannabis, and then I really started to learn from the patient and then started treating the whole patient. And I realized that physical pain is just one component of pain management. And a lot of what I was doing was really just treating the tissues and not really looking at the whole person and the emotional component behind pain. And so I learned a lot of that from cannabis because the patients would tell me they would sleep better, their mood would improve, they would be less anxious, and also their pain would improve. So obviously, I think there's a lot that we can study with the endocannabinoid system and how that relates to even, the serotonin psychedelic receptors. But I started to change how I practiced and be more integrative. And in my fellowship at University of Miami, like 12 years ago, I used ketamine for chronic pain, mainly for complex regional pain syndrome, which is a sympathetic nervous system, a painful condition. And
where was your residency?
University of Miami.
Great.
And we would do ketamine infusions, every single day for a few days in a row, not really paying attention to the psychological component behind what's happening to the patient. And so, about 3 years ago, I started learning more about how the psychiatrists were using ketamine. And I was kind of like blown away by the fact that I didn't understand the true mechanism behind it and what was actually happening to the patient while they were on ketamine, as a fellow. So I really started integrating ketamine assisted psychotherapy into my practice. And so mainly now I'm using cannabis and ketamine to treat chronic pain. And I just was really fascinated by why some people have acute pain and it goes away and their body is able to heal, and why other acute pain turns into chronic pain. And there's this whole, process of central sensitization that happens, which we can discuss. And so I started to do my own research, and I've done research looking at high versus low doses or psychedelic versus psycholytic doses of ketamine for chronic pain and depression, and really just trying to use that biopsychosocial model to treat pain. And I realized how much chronic pain has to do with trauma. And if they weren't treating their trauma and they weren't really, feeling their feelings, and they were just really becoming these people that were, instead of using pain as a protective mechanism, it really was becoming like a learned behavior. And so there was so much that there was so much hope that even just giving someone the option of cannabis or ketamine assisted psychotherapy offers these patients in chronic pain. And there's so much to understand about the pain generators and why it becomes a chronic process. And a lot of it also has to do with neuroinflammation and this, imbalance of pain amplification and inhibiting the pain. But and what I really do is harm reduction, so it's really trying to use other healthier plant-based substances to help the person realize who they truly are and get to the root cause of their pain and suffering.
Mm, beautiful.
Yeah, so South Florida is interesting, because we have so many patients just wanting the quick fix, the opioid, the benzo, the antidepressants don't really work anymore. And I have practices in Miami, in Hollywood, and Boca, and the demographics may be a little bit different, but the underlying theme is still kind of the same. It's, why do we have so much chronic pain, and why are people really suffering so much? We live in such a beautiful society, especially in South Florida. People move here to get rid of their pain. They think like this environment will be a better lifestyle for them, and still there's so much suffering. So we're all very busy down here.
I bet. Not only like a wildly diverse population, like I consider it like Hispanic culture there, like a Caribbean culture down there, like not even kind of like similar culture to the rest of the United States, which I think makes me love Miami and South Florida even more. And not to mention like the age diversity too. Plenty of snowbirds. So probably plenty of old people you can work with too down there. I'm kind of curious about this comment you made before we started recording about fibro. Is there any, could we expand on that briefly? Because it's such an interesting concept to me of,
So like I'm I'm a partner in a practice called Spine and Wellness Centers of America. We have 12 interventional pain physicians. And I just, for some reason, either gravitate towards the fibromyalgia population or they gravitate towards me. And it's really because I was just curious, what is truly like the mechanism behind why they're developing fibromyalgia, and why, when I'm like sitting in a room with them, can I pick up on the fact that there's more to this than just what's happening to their physical body. And honestly, it was just sad because there's no good treatments. The medications don't really work. We understand that, but they're still in pain. They're not, this is truly happening to their body. And when I started thinking more about post-traumatic stress disorder and realizing that oftentimes there's some type of trauma where maybe their body is in this hyperreactive or hyperalgesic state. And then it becomes this wind-up phenomenon where you can't really, where the peripheral pain or the peripheral instigating like injury turns into a central process. And so now the pain or the trauma is actually now in the brain. And that's really central sensitization is. And to reverse that, the NMDA receptor actually plays a role in that, and so does glutamate. So I started thinking more about if they're using ketamine for post-traumatic stress disorder, or if we're using ketamine for complex regional pain syndrome, which is a sympathetic nervous system painful condition, then with fibromyalgia, there must be more of a central component that we're missing. And why does their physical pain show up in multiple places, and you can't really explain it with anything, on diagnostics or anything like that? And I think honestly what's happening is that not only is there inflammation in their body and they have this central sensitization, but their stress response, their fight or flight, similar to like the PTSD type of condition, and the brain doesn't know the difference between emotional or physical pain. So that they're just in this chaotic state. And so this imbalance now becomes like a learned behavior that instead of just using pain to protect themselves, they're actually in chronic pain and showing it in terms of lack of sleep and depression and physical pain. So you can't treat fibromyalgia the way you would treat a physical pain condition. You have to treat fibromyalgia from a central mechanism. And that's kind of the beauty of ketamine. Like that's why you can use a dissociative anesthetic as this catalyst to not only work on the neurobiology, but then say, did you have any past trauma? How has your life, how stuck have you felt because you can't do certain things that you once did? And like, what is limiting you, and what are the beliefs you have that are limiting you? And is it more than just your physical pain? Is it like now it's just more of a protective thing of saying, I'm not going to do that because I have chronic pain. So it's and then the other thing is, how many fibromyalgia patients do I have that I have done ketamine assisted psychotherapy and realize that maybe there was some type of sexual abuse, or maybe there was really like a big or little trauma that then started this spiral, and they weren't able to really calm it down, and they weren't able to get into that parasympathetic mode, and they felt hopeless. And it's it's interesting because I recently read an article that was in JAMA Psychiatry, and they took patients with chronic low back pain, and they gave them the regular, anti-inflammatories, physical therapy type of treatment. And then they compared that to 8 weeks of psychotherapy. And then more than 66% of the patients who got therapy completely had resolution of their back pain, as opposed to the other group that had the normal standard of care. It was about a third that improved. So it was just showing how there's such a psychological or emotional component behind physical pain. And unless you're really treating the whole person, which we don't do because we have 5 minutes in the room and we're looking at MRIs, and then, we're offering like a medication or an injection, and that's like the sad part about Western medicine. And that's the exciting part about personalized medicine, plant medicine, and teaching the person. Like all I do is teach the patient how to use, for example, cannabis to optimize their well-being. And then depending on the time of day and kind of what they're feeling. And ketamine is similar. It's personalizing the dose, the route of administration, how long the infusion is going to be, or the intramuscular, who their coach is, who their therapist is. Like I'm like a big teamwork type of person, like I love working in groups. And I think like the therapeutic alliance is the key to success with any of this.
Yeah. Awesome. That's such an interesting way of looking at it. And I love that. I'm always about how do we empower the individual? It's always a complicated discussion, but yeah, how do we give them more agency? Diet, probably all sorts of other things that can play in here. But yeah, pain management, it's not just about like an injury, right? Radiating pain. It's like there could be all sorts of other things going on. Yeah.
And honestly, like they have to teach that to the pain fellows, right? Like there's this whole concept of nociplastic pain. Like it's not really nociceptive, which is like in the periphery. It's not really neuropathic, but it's nociplastic. And there's irritable bowel syndrome, even IBD, fibromyalgia, pelvic pain. That's a huge, chronic pain population. And because there may not be good current treatments, we just kind of lump these patients into like the chronic pain. And when I see these patients on opioids, I'm like, who's doing this? This is not a good solution. And it's just sad because it's just this concept of like muting the patient or numbing the patient, as opposed to like, what can we bring out in them? When were they once healthy? And, how can we help like align them and really just like make them feel that there is hope, but reverse some of this. And I love the fibromyalgia population because I have good options for them. Like the other physicians in my practice, they just send them to me and they don't know what to do with them. And that's totally fine, because I really think that we're missing the boat on how we diagnose it. And we're forgetting that central component. And so if you're not using a therapist or a coach, and we're not allowing them to kind of like expand their consciousness in that way, then they're going to really feel stuck, the same way that someone with PTSD, is stuck based on their past trauma.
I love that. So Julie, I totally understand now why you've roped in Dr. Weiner here. Beautiful explanation. And like, there's so much depth here, right? And I don't know, Julie, there's a lot of male listeners out there, so I think women will already get it. But like, why? I'm going to ask the most obnoxious question ever to you. But like, why do we need more women represented here in the psychedelic space?
Not an obnoxious question. I think, what's interesting is you have two taboos, right? You have psychedelics, and then you have women stuff, right? Women issues, personal women stuff, right? And so when you think about, to Michelle's point about practitioners, whether clinical, therapists, this isn't just a medicine that someone gives to numb someone. It's a medicine that someone gives to get to the root of somebody's trauma. And when you have females that have undergone trauma, whether it's due to a sexual issue, other things, having women in the industry as practitioners is extra important to create a safe space for women, depending on what their trauma is, that they may not even know until they're in the room, right? Mm-hmm. Also, women, you need more women in the space as investors as well, because historically, female-founded businesses are underfunded by a large percentage versus male-founded businesses. Mm. So when you have female investors in the space, you have more female founders in the space. So it's a whole 360 cycle that isn't just in terms of the clinician patient aspect, but in terms of, leveling the playing field for all people participating in an industry. Mm. Was that an obnoxious response or
no, it's a great response.
Okay.
And Michelle, do you have any opinions on this topic?
Yeah. And it's funny because I work closely with Dustin Robinson, who's an amazing force in,
I really like Dustin.
I would say this whole space. He founded Mr. Psychedelic Law, and I'm the vice president of that, where we're making legal reform for psilocybin mushrooms in Florida. And I'm also a clinical advisor for Eater Investments. And the most amazing thing is I'm the only woman on the whole advisory board, right? Honestly, it's so much fun to work with them. It's different for me. It's not clinical, it's not research, it's not teaching, but it's really great, being on all these calls and learning about different companies that are investing, that we're thinking about investing in. And I'm just fascinated by how much research is going on and just all specific conditions and how they're changing around, these chemical entities. And it's very exciting, but it's also interesting to see how different it is with just all men. Women have this natural way of wanting to connect, and wanting to collaborate. And I think with psychedelics, it's a little different because I think people are a little bit more open-minded. They're a little bit more even touchy-feely, even for men, so I think they're getting in touch with themselves in a different way than most businessmen would. But I just think women have this natural nurture, I'm always the type that, and I'm also a mom, so it's just kind of, and it's just in me, but just to connect, we want to connect on some level. And it's nice working with all these men, but it's just we have to change the stigma about psychedelics, but we have to change the stigma by then having a broad demographics talking to the population. Because if only the white men are talking to people about psychedelics, then who are the minorities going to trust? Are they going to listen to them and think, oh, this is safe, this is okay? Or they're not going to be able to feel comfortable? And that's a big deal, especially in South Florida. I mean, I even get that speaking with a lot of Hispanic patients, just being white, there has to be something you connect on. But I think that because this space is a little bit different in the sense that most people really do care, or at least the ones that I work with actually do care. Even if they're businessmen, they understand that there is this mental health crisis. There's a lot of chronic pain and they want good solutions. They do want to make money also, but I don't think anyone's trying to hurt anyone. And I think just by being able to connect, even the men, I think that it's it is what it is, but I even think it's a nice window for men to be able to start having the conversation and being comfortable talking about their feelings and their personal experiences. Dustin always asks me when I'm on a panel, tell me about how you got into psychedelics and any of your experiences. And you love hearing that from other men and women and other professionals too, because you want to know, and that connection comes out where their actual true love and feelings behind why they got into this. So I feel the passion's there for a lot of these people, but I like working with women. my therapist, my coaches mainly are women. like I think the patients sometimes just like to kind of, they get more comfortable in the space with it. Like, how does a woman hold space versus a man? It's very different. Like,
Mhm.
why is that, and how can we change that? I mean, we're changing things little by little, but I know, like, personally, the coaches and the therapists that I use, my nurse practitioners, are mainly women. And I don't know if that's because they gravitate towards this field, or
Mm.
because patients gravitate towards them, but there's that nurturing, like, innate property of being a woman that also is like special and unique, and we can use to our advantage in that sense.
Yeah, absolutely. Like, I think any kind of diversity amplifies impact and intelligence and maybe even resilience. So there's a lot here. Yeah, and you mentioned distrust in the medical system. Like, I know a number of guidance school counselors and people working in mental health care, and there's very big differences culturally between how Caucasian people and Hispanic folks kind of think about mental health. I know some people who aren't really even allowed to go see a therapist because of their culture. Like, I don't want to show weakness. Have you either of you seen that before?
Yeah, I mean, I've definitely seen certain populations, like, even when I say the word coach versus therapist, like, like, and it's just so interesting because, and that's kind of like a good, that's an interesting topic anyway, but like, there are certain conditions obviously where I much rather a therapist work with them who's like properly trained, but then there's so many therapists who don't have enough information about psychedelics and ketamine to properly guide them. So, but it's also the way that the patient responds to that word. Like, a therapist, like, they'll think, I don't need, because the way that they think about therapy is just hours and hours of sitting and talking, as opposed to the concept of a coach. They think it's a little bit more focused, intention setting, like peak performance, health optimization. So it's almost like less in the sick role, So I think, yeah, but I do think certain populations are not as willing to go to therapy. I think, like, I have some men who only want a male therapist, and then I have some men who only want a female therapist. But everybody's different. But I think the important thing is, like, to have the right team or of extenders, or even just to, like, be able to collaborate with different professionals in the space to know. And that's, like, honestly what I do. I do, like, triaging. It's like, well, are they,
Hmm.
a chronic pain patient and need an infusion? Are they mental health and maybe more of intramuscular and therapy? We do, like, microdosing during therapy sessions of ketamine. So I think it's like knowing the person and having that feel for, like, how they're going to respond to this, and then having the options. Because if the patient doesn't feel comfortable, it's like saying, what did your therapist say? And it's like, oh, I would never tell my therapist that, right? Like, they have to feel comfortable in that space to get to the next step, next level.
Mm. Julie, have you seen anything about this, like, coach versus kind of therapist angle? I find it interesting. I don't really know how to couch it yet, but I do think it's a really interesting kind of development in the space, moving away from licensed professionals like clinical pros.
Yeah, I think it's just a more constructive way to think about it and talk about it. I think therapy has a stigma and it's helpful for some and not for others. And culturally, yes, there are certain cultural segments that it's more of a stigma to go to therapy than others, admitting you need help, things like that. It's funny, I actually went to a hypnotist recently, and when you lie down, he asks you if you want the blanket. And I say yes. And he says, and I asked, do most women want the blanket and most men don't? And he said, exactly. Not one man has used that blanket. Right. So, it's something to be said where men, African American population, less likely to go to therapy. I work with Nue Life. I'm the head of strategic partnerships. And actually, through the app, we have health coaches. And what I like about that is rather than just focus on the trauma and the pain, with coaching it feels like a step forward. It's what's your purpose in life, where are you going with this?
Hmm.
And so I think when you think about psychedelics and integration, a health coach or some kind of coach is important because therapy it helps you get to the root of the trauma, but the goal isn't always to address what's your purpose in life, right? It's to kind of heal the wounds, but it isn't always so forward facing and plan of action creation, right? And there's a huge health coach community now, of course, with Instagram and all of these things. People have been able to create their own businesses, and it's super accessible to find these coaches. And, I think that is an interesting segment that is going to emerge here in psychedelic space, where it's these psychedelic specific coaches to help guide people post experience through their integration to help find that way forward.
Mm-hmm. And Michelle, maybe this is like an interesting question and segue for you. Like, do you see any kind of explicit limitations in the purely clinical model that might kind of hold people back, or any kind of limitations? I don't know, like performance, maybe specifically in outcomes.
Like you're saying, like the clinical care that we're delivering, any limitations in that?
Maybe more with like therapists, like, because obviously we need a physician to administer ketamine in most cases, but right. There's some limitations on what therapists can do, right?
Well, so I work like specifically with a really amazing therapist. Her name's Sherry Kaplan, and she has a lot of experience with psychedelics, plant medicine, ketamine, and and cannabis, very open-minded, kind of out of the box anyway. And that's why we work so well together. So, it's a nice like back and forth of, she's usually there. When I work in her Boca office, she's there. So like, it's like a layup shot. It's like she, really like I meet them first. I really have them understand, the mechanism of ketamine, and we kind of pick like the route of administration and have an understanding of like the dose that we'll start at. And then she really gets into like their past, their trauma, like full history. I find like perhaps coaches may not go as deep into some of that, but it's so interesting for me to watch when I send a patient to her versus maybe one of my coaches. And honestly, the coaches do a great job, but there's such a difference in information relayed to me. Like, and that's why, and first of all, there's a difference in costs. Sherry's probably like twice as much as the coach would cost. And she has, years and years of experience, but she also works with more of my challenging patients, like my true trauma patients, my real treatment resistant depression, PTSD, and the chronic pain patients who want to resist me and say that they don't have any mental health problems, even though they have chronic pain for 20 years. And then with the coach, it's a little bit more of the person who's kind of like personal growth and development, psychospiritual growth. They feel a little bit stuck. They want to see like what other opportunities, they want to connect deeper with themselves. And so it's like a different person, it's like a different like referral for me. And so I think they really do have a role, because the cost is going to be different. The depth of it's going to be different. The coaches don't have to be every single time after, every single ketamine session, for example. And then we have other ones where I'm so thankful I sent them to Sherry, because they start having, anxiety during the ketamine experience, or just setting them up right before their ketamine is so important. Like even that 5 or 10 minutes of like really getting them into that parasympathetic state, understanding what that specific focused intention is, and then her knowing them really well really makes for like a much more successful. And also I love like asking her, what do you think the dose should be today? And like kind of us going back and forth, I love that like team approach. And I think the coach definitely has a place, but ultimately the biggest limitation is the cost, right? Like if we can just get this covered by insurance, then life would be so much easier. We would be able to train more clinicians, and then just have things just, and it still has to be personalized, and we still have to have like people there and assisting. And, I have a nurse practitioner who sits with them, and then other like RNs who are with them. But it's just, it's just so sad that something that may be such a great option for people can't be an option because of costs. It's just very frustrating, as opposed to like your pharmaceutical, no problem, we'll pay for your opioids and, benzos. That's that's my like biggest limitation right now, and my biggest frustration.
I love that. Yeah, totally. Like there's definitely people I would need to send to a licensed person. But there's plenty of people I think would be totally fine working with coaches. It's kind of like a case by case basis. And yeah, totally, expense is a really big factor. But yeah, it's definitely a long, complex conversation. I really hope that we get some sort of insurance inclusion soon. I know that there's people working on it, like multiple nonprofits are working on this. So I'm hopeful.
I actually I bill the insurance for the infusion, and whatever the insurance pays me, I pay the patient back. That's usually what I do, because I'm on all the insurance plans. And any infusion, intramuscular, it doesn't seem like they're accepting that route yet. So it's just basically for infusions right now.
Interesting. But that's good to know. Yeah, infusions. I see a lot of people get covered for that. I was actually, I've got a little bit of chronic pain. So I'm actually kind of looking at what would an infusion look like and can I get it covered? Kind of out of curiosity, but also, perhaps it would help a bunch. Like, do you see any kind of like long-term durable results from infusions?
From infusions and chronic pain?
Yeah.
Yeah, I'm really open to like learning from other practitioners, and I would love to talk to other physicians who are doing this, not just like therapists and coaches, because like the decision for the patient in my mind for intramuscular versus an IV infusion, generally my chronic pain patients will be more of an infusion. And I have that like mentality of like the longer that their central nervous system is being bathed by the ketamine, the longer the potential for pain relief. And I think that kind of started from my fellowship, that concept. And so sometimes like we can do a 3-hour infusion for chronic pain patients. And as opposed to like most of the mental health ones are more, a 60-minute or 45-minute infusion. And I generally will do more intramuscular for those patients, because I actually do like a stacked protocol where 15, 20 minutes later, I come in and do like a second injection. And I like to be around and available and understanding how they're feeling and what they're going through. And sometimes, they don't really need that mystical experience. And a lot of times it brings on fear for people. And so, we can very much control the dose. The biggest limitation with intramuscular is you get all the medicine at once, obviously. And at the same time, that also is like part of the healing process, right? Like the fact that they're going on this journey. But it's either way, it's dose, it's completely like based on the dose. And that's what I think really, like when people think about ketamine and they tell you the horse tranquilizer and the K-hole, like you have to really, really educate them on the fact that it can be at a lower dose and still get the benefit of it. But I think there's that afterglow effect, which is a problem, and they feel really great in the beginning and we continue it, but it's not like always as great as the first few sessions, and I do hear that a lot. And so it's personalized, like some patients are able to go on that journey and others, maybe the antidepressant effect doesn't really happen with, the mystical experience. I don't think that's like 100% known yet, but I do think that the experience is a big component to it. And when like a chronic pain patient just wants to get the infusions, but not really discuss any of the insight that came up during the experience, I think that they're losing the potential for a longer lasting effect.
Makes sense. Yeah. That's interesting. And obviously I could go down this rabbit hole all day.
But I'd be curious to hear your opinion. Like, have you had like different routes of administration? Like, I know I've done like an oral lozenge in a group setting. I think group settings are amazing. I think like collective healing is a great way of using ketamine and having like, that just being able to connect with others during this process. And I think that's like a very powerful way of doing it. But obviously the dose is not going to be as high as like an infusion or, intramuscular maybe.
Right. So the 2 times I've had ketamine alone, I've had a lot of surgeries and ketamine was in the cocktail, but I've had 1 intramuscular injection and 1 lozenge session. Lozenge session was 100 milligrams under the tongue for 15 minutes. It was interesting. For a lot of people, it's like their favorite thing in the world. I'm like, cool, but I didn't love it that much. I didn't hate it. It was nice and pleasant, but I'm not like over the moon. I felt a little bit of a relief. It was part of a CAP session. So, I was in with a therapist and working through kind of somatic stuff, and it was interesting. I had the intramuscular injection, 86 milligrams. I'll give up my weight. It was 1 mg to kg, so 86 kilograms at that point in time. And it was pretty extreme. It was interesting. I was totally fine with dying. It was no sense of name, body, identity. All that was kind of like interesting abstractions. It was interesting. And that wasn't really part of a CAP session. It was more just like a friend of mine said, hey, come on down to the office and let's try it out since you haven't really had ketamine outside of a large cocktail. So, it was interesting. It was helpful. It wasn't really for chronic pain or anything, but, I think I had some sort of, relief physically for at least a few days there. I think from both, honestly. Yeah. But, this is, one session each, like a year plus apart. So it's like, it kind of has to be in a tighter timeline, I think.
But even doing like 1 milligram per kilogram, like an 85 milligrams for the most part, I find is like a complete dissociation. Like, the patients usually,
sure was
full ego dissolution, like either just like quicksand into the recliner or, like in, meeting like heaven, right? So I think that happens oftentimes with a 1 milligram per kilogram intramuscular dose. Had you probably had the 86 milligrams in an IV, it could have felt much different because it's more of a linear type of feeling. And so there's like, right. So there's that, sometimes patients, if they're not getting better, they'll question the route of administration. I think that's totally okay. But I also think they probably knew you could handle 1 milligram per kilogram in an intramuscular dose, right? As opposed to other people, they need to start low and, increase the dose slowly and understand how it makes them feel. But I don't know, maybe some people are more aggressive with the dosing and maybe some practitioners are more conservative. And I think that's also a component of it, like it's not just we do 0.5 milligrams per kilogram and then go up. Like there's so much more to the picture with how we're going to dose and then what route we're going to do. And, a lot of it, again, has to do with cost and time and then previous experience, or if they have like history of OCD or anxiety, I'm not going to, make the dose maybe as high. Right. So that's interesting that you got that 1 milligram per kilogram, because that's like, full, there's no cap during that time. There's no talking.
And it was more like, this guy's been around the block, me. But he hasn't had this experience. Like, let's just make sure he has that under his belt so he can speak to it. And that was more the intent, I think, than anything. But it was pretty interesting. I could have handled higher, I think. Would I care? I don't even know what actually would have happened. It was pretty extreme. It's about as extreme as I could imagine anyway. Full dissolution.
I have a great coach. Her name is Janelle Becerra, and she had a specific intention, and she kept saying, I want to do intramuscular. I've only tried like an oral lozenge, and I did that. I did a 1 milligram per kilogram. That was exactly what I did. And she was like, within 10 minutes of that, I actually already got the answer to, like what the specific intention was, what her question was. And it was like it was a perfect dose, but that's because it's someone who has done psychedelics before. And I understood that, and that was it. Like, as opposed to someone who, and that's because she's a coach, and obviously now she's integrating that into her life. But it's just what I fear is honestly people who really don't understand ketamine, or maybe like the anesthesiologists who are coming and don't understand that emotional component doing these infusions. And like that's kind of, that is a fear of mine, and not really being able to manage what's happening during it, and then giving ketamine a worse name than it already has. Especially
it's kind of horrible. Like, horrible is not the right word. Troubling is probably the right word. I'm an anesthesiologist. I give this drug to people all day long. Like, I don't need to learn anymore, or communicate with other people who have a lot more experience doing it in non-surgical settings or non-ER settings or something. Right? I don't know, Julie, have you seen stuff like this with your work at Nue Life?
Yeah, I was just going to say, Nue Life does dose discovery. So any new patient, whether they've had ketamine before or not, they go through a dose discovery process where they're sent one. So Nue Life has ketamine at home treatment. So it's a telehealth companion app, and it's a 6-dose protocol over the course of roughly a month, and it's at home lozenge. So, the dose is, on par with, an IV type treatment, but it's able to be done at home. It greatly reduces the cost. There's health coaches. So, it's not always a one-on-one therapy session, which also greatly reduces the cost and makes it more accessible while still being super effective. The results are insane. And what I love about it is this dose discovery, because if you've never done it or you have, they just want to make sure that you're getting the right dose, and they just send one at a time in the first go. And then as you go along, then they increase it based on your personal experience. And there's tons of metrics and data and, best in class practices that they do that with. So I think if you're getting into it and you're doing, it's not so regulated, right? There's not an exact dose. It's very personalized. So I think it's super important, for anyone getting into that practice to make dose discovery a part of the process. To Michelle's point, there's already a bit of a stigma around psychedelics, and extra stigma around ketamine. So you don't want yet another stigma around, dose questionability or anything like that. Yeah.
Yeah, I love it. It's a big topic, and it's important to discuss this stuff. Like, one thing that we don't like to talk about when we talk about ketamine is sometimes people get nauseous. Like there's a certain percentage of people who are not going to enjoy it because of the nausea. Typically they get stacked with another, what's the term? Antiemetic.
Yeah.
Yeah. I've been around long enough. I got that one.
Well, I think people are under the impression that psychedelics are always meant to be enjoyable. And while ketamine oftentimes is enjoyable, and sometimes, it's meant to be part of a healing journey. And, so just like, ayahuasca, some other things, it's not always, every minute of it isn't always meant to be enjoyable. And that's part of the journey.
Totally.
Yeah, I think like I'm very big with like giving a preventative for like nausea. But, even I do some at home too, and I'll send them like Zofran with their ketamine lozenge. Everyone who I do ketamine on gets like Zofran or Phenergan or promethazine. So like we'll definitely, but that's like the physician in me that tries to always prevent that. But then it's interesting to see who, like I had a patient the other day that literally at the end of his whole experience, was probably like almost 90 minutes into it, he just got up from the chair and literally vomited. And he was like, I had the most amazing experience. And then like it just happened. It just like came to him. And of course, like one of the coaches I was with was like, what was happening during that time? Is this part of the process? Like everybody has their own thought process behind that. But I do think that like preventing as much of that negative like aftermath is helpful. And I think I think a lot of that has to do with proper preparation. Like even I had a patient today that I've been doing at home ketamine for, and she came in just actually for her cannabis recommendation. And she, the prepper, like she was like, as much as you prepared me, you still don't know until you do it that first time, like you can read about it, you can hear about it, but until you're actually feeling it. And then based on, every person's a little bit different. I think the doses are different. I love the dose discovery thing. Like I have some patients that are, mental health patients, and I'll do an intramuscular injection on them like every 8 weeks or every 10 weeks. And that's just their cycle. We found their dose, and then they just come in like every 2 to 3 months. And I'm not saying that's like the best treatment, but that may be the best treatment for that person, so I think the dose discovery is a great, no matter what route it is. And also just, having them like know what to expect, know their body, and then properly be prepared with their music and their headphones and like a quiet space. And, that whole thing is so important.
Right.
Not just the integration, but really like the preparation.
Yeah. Yeah. And it's like the best protocol for them now, right? Like science keeps progressing. So we're going to have better options. It's just a matter of time, right? I like to preach optimism.
The, the music is so big, like I was just talking to the guy from Wave Pass, and he was saying how music is the what is he called, the hidden therapist, right?
Were you on
And
with
like,
Mendel, Kaylin?
yeah,
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 brilliant character. Yeah,
brilliant. And like, when people like get interrupted in the middle of their session, how disrupting it is, obviously, but also like, that's it. Like, you're doing your session, like there can't be interruptions. The music is key. And for him to be like, it is the hidden therapist, like what he is actually, and the fact that you can pick it. I think Nue Life does that too. And I think they do a really great job of that. And that's why like it becomes more affordable, and people have more access to it. And like, that's why there's so many, like, we're all able to be in this space. There's something for that right person. I love what Nue Life's doing with the music as well.
Yeah, it's what I found really interesting when I had my session. I want to talk about Stan Groff right after this. When I had my 86 session, I had I've been around the block, so I had the right playlist for me. A lot of cigaros, partly because I didn't have a great amount of time to prep a playlist. But I was told by this psychiatrist that a person a few weeks earlier just really wanted to listen to like Pink Floyd, like Dark Side of the Moon or whatever. I'm like, are you guys what? Like, I don't know that that's a great idea, but did it? Turns out it wasn't a great idea. But I find it fascinating. Yeah. And there's going to be a lot of iteration because there's so many sessions happening now that with technology, we can iterate towards better. Which is going to be awesome.
Right. And everybody likes something different. Like, I have some people who love classical. I have some people who are like totally into the meditation and more like yoga. And honestly, I have this one patient, and she is a chronic pain patient, and she gets probably a 2-hour infusion, and she won't listen to anything I recommend. Like, everything has words and it's loud, and like I hear it through her headphones, and I'm like, this is not a good idea. But she's like, this is the music that speaks to me. And it's like, I know better, but she's not going to listen, like I can't force her to do that. But I actually think that it's not allowing her to get further. Like, I think that's part of the process. Like, think about it. Like, a person like that who's even resisting the advice that we're giving, like, that's part of this process. Like, even think of a chronic pain patient. It's a constant fight or flight type of, like, overprotective type of way. And she's even controlling the music, and that can't be helpful. Like, how is that a good tone? Or like, even the words that are coming through, that's just so directive, as opposed to non-directive, or non-guided type of, like, get out of your, consciousness. So it's a big part of it.
Yeah, it's important. And, I had zero music for my lozenge session, which was a first for me. Psychedelics have always previously been done with music. But what I found really interesting, and I found this out somehow quite recently, I should have known this for a long time because I have a deep obsession with the work of Dr. Stanislav Grof, is in a lot of the early LSD sessions, there was no music. Music came in to Stan's world through holotropic breathwork.
Interesting.
So I've sat in a lot of holotropic breathwork sessions, and it makes a lot of sense to me. Yeah, I think really, again, we'll just come back to the client in these kind of sessions needs to figure out what's right for them. But in your case there that you just kind of shared, it sounds like sometimes the clinician might need to butt back a little bit.
Oh yeah, no, I honestly, I'm like, listen, we're gonna do. I send her emails with playlists. I'm like, before your next session, listen to some of these and tell me if any of these resonate with you. And she comes back, and then actually she had a session which was like very uncomfortable, and I said perhaps it was the music, like I think that was a big component to why the session wasn't as effective. But yeah, I agree. Like, we have to butt in there a little bit more to make it a little bit more successful. But I also think, like, what you're saying is just even teaching the patients to learn how to breathe and to meditate and to get into that state prior to their first session is also really helpful. And I think they do listen to their breath. Like, sometimes the patients get a little bit nervous when they get deep into the session, and they literally say, like, oh wow, I almost thought, I forgot to breathe. And I'm like, we don't have to remember to breathe, but like the actual respirations changes, and it makes them a little bit anxious as they get deeper into it. And if they're not really well versed in meditation or breath work, it becomes a little bit, it was like potential anxiety for them. But then when they hear their breath, it actually brings them back, which is so powerful. So even when the song ends and then changes to a different song, they hear their breath. And like that alone in that second is like a moment for them to connect with themselves in a different way.
Mm-hmm. Yeah.
Joe, I wanted to circle back on something when we're speaking about connection. And, Michelle mentioned Janelle Becerra before. In the group that we have right now, we have a 55 founding members for Psychedelic Women, and it's a WhatsApp right now until we build out the bigger platform. But what's just so amazing in there is that connection, women sharing, asking for advice, inviting each other to events. A bunch of us are going to. One of the women in the group is a Kundalini teacher. She holds space for about 70 people every other week. So we're going to that. Someone just posted right before this about an advocacy event to attend. So I think back to your question about, why do we need more women in this space? The reason for Psychedelic Women isn't just about helping more women get into the space, but to make a connection between women where we can support each other and help them pursue what they want to pursue and support each other and connect. Michelle can attest, the vibes and spirit of the group is just so inspiring and helpful. And I would say, like Chief, the women's networking group for executives, or like Hey Mama for career women that are moms, Dreamers Doers, which I'm a member of, which is like an entrepreneurial women's group. Psychedelics doesn't exist just in a bubble. We're all joined by psychedelics, but what's interesting is some of these women are moms like Michelle. Some of these women are entrepreneurs like me. Some of these women are executives, like Brenda, so we have investors in the group. We have medical professionals like Michelle, like Lynn Marie Gorski. We have investors like Sylvia Benito, Maria Velkova, that speak on all these amazing panels. And to have that direct access to each one of these women on a regular basis is just, when you talk about connection, it's just really a powerful thing.
It is. Yeah. I think it's so, first of all, I think you're amazing that you started this, and you're such a connector. Like that's just like in your blood. You're like that, that person who like like a matchmaker. Like you're such a great connector. You're so good at that. And I think it's a really good outlet for people. I know of multiple nurses who want to get out of hospital work and go into psychedelics that have contacted me. And like, it's like a career building like opportunity for these people who are feeling stuck in what they're doing, finding other people who have the same type of passion and interest that they do, and then trying to collaborate. Like I think and that's kind of the beauty of like working with women, like I don't think there's not really much competition in that group. It's really trying to help bring out, what do you do? How can I help your business? How can we all collaborate? And like, how can we learn from each other? And it's really, it's nice. Like it's a very nice group. And I think it's all part of the journey, like we're really meeting a lot of new, interesting people, and it's adding to like each of our lives. So thank you for making it.
You're welcome. You're so welcome. And I think as it evolves, it'll continue to be more resourceful. I saw someone post like, please, someone start, a job resource for psychedelic industry related jobs. What if that was part of Psychedelic Women? Different speaker series is what we're doing now, but how can we help these women connect? I credit Dustin for bringing us on, and featuring the group at Soho House. And something he said was, it's not that I don't want to feature women on the panel. I just need more women in the space to feature them. Right. And I think that's an excellent point. And if we can help do something about that, then I think we're winning.
Yeah. And there's so much when you're talking about like lifestyle, and it's more than like, there's people who are personal trainers, dietitians that I've met actually, like there's so many other people that are involved in making this experience more effective for people. Like, it's not just the medicine and the doctor and the therapist and the coach, but like, even like I'm working now with a dietitian who is really healing people's like relationship with food by dealing with their trauma, and then offering them like my services for ketamine as well. So it's like even people in their own field, or like personal trainers who are using movement, and it's like so nice to see, because this is really how medicine should be. Like, it shouldn't be everybody in their own box. Like with other physicians, it's like, pain management, your psychiatry, well, then you need to deal with that and I'll deal with this. But like, this whole group is really bringing people together that have certain talents and passions, and saying we can work together. And I find it so effective for the patients. Again, it's like, who, like, maybe this person needs more of a dietitian and less of a therapist. You know what I mean? Like, so that's all part of, I guess, personalization and health optimization, and stop just like waiting to get sick and ask the doctor for the answer. Like, it's so frustrating. It's like, we all need to take a little bit more ownership and we know things that are not good for us. We know when we're, numbing and having poor coping mechanisms, and like, we have to wake up a little bit, and obviously the medicine helps people, but like, all of these women are so, it's just inspirational. It's really great group.
I love it. I want to support you more. Figure it out. So
we'll figure it out, Joe. Let's do it.
Michelle, great news. We're actually working on hosting a pain and psychedelics conference in a few months. So expect somebody to reach out shortly. See
awesome.
if you can contribute. Yeah, it's such an interesting area of research. I think Stanford has something going on. UC San Diego has something.
Yeah, UC San Diego is doing great stuff, and like, and I would love to even collaborate with some people like that, because like there's chronic migraines, cluster headaches, phantom limb pain. Like, there's so many other really like nosoplastic painful conditions that don't have a good, and we do biofeedback. We do like mirror work, for like groups like phantom limb.
That's great.
And a lot of that, like, you have to realize it's the central nervous system now. This is no longer in the periphery. Like, and you can't get to the root cause of it anymore, because the root cause doesn't exist. Now it's become this central sensitization. So I think ketamine is actually really one of the better, it's a dissociative anesthetic, but better psychedelic for pain. And because it's legal and available, I think we should be studying it more for other painful conditions, even though it works. It's like we're using ketamine because we can't use psilocybin and MDMA for every mental health condition. But like MDMA for fibromyalgia, that's going to be even more effective than ketamine. But maybe ketamine will be great for like phantom limb pain, chronic migraines. So there's a lot of other conditions that I hope will be studied using ketamine. But honestly, I can't wait for MDMA to be available. I think that's like a home run for fibromyalgia for sure.
Let's find out. Do I have some connections for you? Yeah, I can't wait to hook you up with everybody. Well, this has been amazing. Thank you both so much. Any kind of closing thoughts or websites you want to shout out, or mentions or thank yous or anything?
Well, thank you, Joe. Thank you, Michelle. Yes, psychedelicwomen.co is the website. We are going to be taking applications for membership, and we'll have some exciting news to come.
Amazing.
So thank you so much. And you could follow me. You could follow me on Instagram, Julie Good Juju, and Julie Zukof. You could find me on LinkedIn.
My website is drmichelleweiner.com. I'm in South Florida. My Instagram is Dr. Michelle Weiner. And I would just like to leave having people just, open their eyes to patients with chronic pain, and really looking at the fact that there's a huge emotional component behind that. And if they don't really get to the root cause, then they're not really giving proper hope. And a lot of these people just are feeling like they don't have purpose in their life anymore. And really, you need like a good team to help these people get out of the spot that they're in. So I'm very hopeful for the future.
Amazing. Yeah, that's my way of saying that, Michelle, is make it a team sport, like on all levels.
I agree.
You got to build that tribe, and it's really essential. Yeah. Well, again, thank you both. And I really hope we can do it again.
Thank you.
Same. Thank you. Thanks so much.
And there you have it, Julie Zukof and Dr. Michelle Weiner. I really appreciate you both being on the show. Really enlightening conversation. I kept getting sidetracked on the clinical, so hope that wasn't too distracting for you all. But really fascinating material from Dr. Weiner there. So I hope you enjoyed it, and hope you all learned something great. Please do send people that way and follow their organization. Really cool project, and really hopeful for what it might bring. So, all right, I think that's it for now. This is Joe Moore signing off. Thank you all for tuning in. Couldn't do it without you. Take care, everybody. Bye-bye.